My name is Marissa Goninen, and I'm the manager of our virtual population health pharmacy team at Advocate Aurora Health. And I'm also the chair of our educational programming committee, and I'm really excited to introduce this topic to you today. What a great morning to kick off day one of the 2024 PSW Educational Conference. This afternoon, we have a full schedule of educational sessions, WPRC, the Wisconsin Pharmacy Residency Conference. Resident presentations are also available aligned with concurrent educational sessions. I encourage you to review the PSW Conference Companion app to see the full schedule of events for this afternoon. As a reminder, all continuing education credits should be claimed through the app, and attendees will be required to complete a brief quiz before claiming credit. Remember to claim your CE as soon as possible, as the window to collect conference CE closes after 60 days. Our speaker, Dr. Abbi Linde, will provide a presentation entitled Processed Food Addiction: An Alternative Perspective on Chronic Disease. Dr. Linde is the Managing Network Facilitator for CPESN and a Willpower Coach. As Managing Network Facilitator for the Community Pharmacy Enhanced Services Network of Wisconsin, Abbi supports Wisconsin community pharmacists in implementing sustainable clinical services and establish value-based reimbursement models. Additionally, Abbi works directly with clients striving to optimize health using lifestyle changes. Please help me in welcoming Abbi Linde.
My technology turned on. Oh, that sounds bad. Okay, hopefully there'll be no more of that. Does that hurt your ears like it hurts mine? Yeah. I think I can be restrained to this. I think that's fine. It's okay. I'm sure. It's fine. Yep. I am going with the flow today. I left my notes at home. My watch is stuck at 11 o'clock. So it's fine. We're all fine. It's gonna be great. So I'm Abbi. I am hoping to share with you today a bit of a different perspective. I don't know. I'm assuming that many of you have worked with patients that have chronic disease or conditions that could be improved by making changes in their diet and their lifestyle. And you may have experienced some frustration when you have made recommendation, you've worked really hard with the patient and the care team to get a plan in place, and the patient is unwilling to follow the plan. You may have experienced some frustration. You may have had some judgments. Why can't they do this? Are they lazy? Are they whatever? You may have had some judgments. You might be nicer. I'm not sure. But you may have also thought, is it something that I'm doing? Am I not, serving my patients in a way that's actually useful for them to be able to make these lifestyle choices? That might be true. There's an alternate explanation for this as well, and that is that there's actually an addiction present for your patients, probably many of your patients, and looking at it with a different perspective can change how we treat and help our patients manage their condition. So hoping to kind of shed light on a new perspective for you. I also want to make one disclaimer. I really liked I'm calling it a disclaimer, in the narcissistic personality trait talk earlier today. They talked about how the point of this is not to shame anybody because they are making poor food choices or even blame anybody for making those choices. There are lots of reasons how and why people make choices about what foods they're going to eat. Social determinants of health related to access and cost and time to prepare foods, genetic predispositions regarding taste and hunger, cultural pressures, religious preferences, all the things. Many more things than just they decided to eat junk food. So I just want to preface this is not intended to blame or shame anybody who eats processed foods. I eat processed foods. It's okay if you do. And really, it's just about, I guess, number one, removing that blame from the patient, but also it still remains their responsibility. And so if they want to make those changes, and if you want to support them in that, coming at it from this perspective can be useful. Okay, that was a lot of disclaimers. So let's get this party started. I do not have any relevant financial relationships to disclose. Here are our learning objectives. I'm going to talk a little bit about the marketing and advertising that strategically tries to get people addicted to their food so that they can sell more and make more money. But then we'll move on from that and talk more about how that impacts chronic disease, how we as pharmacists and pharmacy team members can impact that, as well as how you can kind of start to identify this in your patient population and or yourself. And we'll go from there. All right, so this may be news to you. It was news to me, but there is a business model specifically designed to get people addicted to things. And it actually it was developed related to tobacco use, highly successful related to tobacco use. I will argue that it is also highly successful related to processed foods. You, as pharmacists, you may recognize this business model related to opioids. Alcohol is another. So it's not really an uncommon business model. It's a very effective business model, actually. When we think back to foods that we used to eat prior to the 1980s, people ate food, gardens, farms, mostly local-ish foods. Since the 1980s, that has changed. And what I'd like you guys to think about, we've heard we have an obesity epidemic, we have a diabetes epidemic, maybe, but it's also probable that we have a processed food addiction epidemic that is driving a lot of this other chronic disease. So I mentioned that this shift really began in the 1980s. I have some specific names here if you're interested. What's important is that the owners of tobacco companies that were being started to have restrictions put on them regarding how they could market, who they could market to. They could no longer target children, for example. They decided to purchase food companies, Nabisco, General Foods, Kraft Foods, big food companies. And they began to implement a similar business model. In an article, it was named the Modern Industrial Epidemic of Addiction Model. Sounds super fancy. Essentially, it's get everybody addicted to this thing so that we can sell a bunch of it and keep selling a bunch of it ongoing and make lots of money, for example. And so that was when this shift began from eating food to eating food-like substances. Very smart, I think. Oh, that's an assessment question. That's cheating. Okay, so very smart people began designing to specifically activate addiction pathways and essentially make it so you cannot eat just one, right? We kind of have all experienced this individually. We've seen other people. It's really quite impressive how good these food scientists are at that. I can say for myself, so I was born in 1986. I grew up in the 80s and the 90s. I grew up eating macaroni and cheese, ravioli and SpaghettiOs. Those were like every day for lunch. The vegetables that I ate were corn and beans out of cans, which is nothing wrong with eating things out of cans. But corn and beans are actually not vegetables. I don't know if you guys are aware, they're legumes and grains. So I just really didn't grow up eating vegetables at all. And that was normal. I don't know if you guys, similar experience, some hands. That was just normal. That's what everybody ate. I didn't realize that that wasn't how it used to always be. Like that was just normal to me. And so I think that we've all had this experience. We know that processed foods are very ubiquitous. And I personally didn't realize how difficult it was to remove them when I began trying to do so. Okay, let's do that learning assessment. I forgot to remind everybody to get out their apps. I hope I don't have to actually do anything in the app. Can you see that in there? Can anyone give me a yes? It's in there and you can see it, answer it. Otherwise, we'll just do it out loud. It's not in there. Okay. So does anybody know the correct answer? The question is, which tobacco corporations transitioned to the processed food corporations in the 1980s? Anybody know? A and B, yes. So some very large tobacco companies, those owners became the owners of some very large food corporations. Good times. Okay, so I want to move on to, and I'm actually going to try to move quickly through this neuromarketing piece because I want to get to the what can you do about it part. But essentially this idea of neuromarketing is, testing when people see things, when people eat things, how does that impact their brain and the brain functioning? And how does that impact their future behaviors and food choices? And so what they learned very smartly was that people don't buy snacks. Also, snacks is like a new concept since the 1980s also. But hunger doesn't sell snacks. Desire sells snacks. The brain putting importance on snacks and thinking they're important, activating that dopamine pathway, and addiction is what sells snacks and keeps them coming back for more snacks. And so there is kind of a way to talk about it. It's called the 5 A's of neuromarketing, and it's kind of got 2 pillars. The first pillar is we need to teach the brain to crave that food. And so one of the ways that they do this is with product formulation. So they make the formulation of the food-like substance. I might say food, but anytime I'm talking about these ultra-processed foods, food-like substance, just sub that in your brain. They started adding things to make them more addictive. And so this is just like a super quick tidbit here. But if you can add sugar to items that don't typically have sugar, like bread, for example, have you ever looked at how much sugar is in like actual high fructose corn syrup is in bread? That stimulates the dopamine pathways. Similarly to caffeine, flour can stimulate the serotonin pathways. Gluten, excessive salt, and dairy can stimulate that opiate pathway. And then certain fats can stimulate the endocannabinoid pathway. And so you can imagine that concocting foods, and I can think of many processed foods that include like most of those things in it, how that could really be activating pathways in our brain and impacting us, beyond what is a normal food that you could get from the ground or, less processing would impact your brain. So they really mastered, by using that formulation, they mastered how to induce cravings so that you cannot eat just one. Not only that, but you keep going back to get more and more. One specific shout out to Howard here. He is the person who discovered this concept of bliss point, this optimal deliciousness. It's just the right amount of sweet, the right amount of savory, the right amount of, deliciousness that really triggers all of those parts of the brain that make you want more. Just had to throw in another shout out since I'm in a room of pharmacists and pharmacy team members. I'm assuming you're seeing the parallels here to the opioid marketing plan. Here, these aren't addictive. They'll work really well and great. Oh wait, they're super addictive and no one can get off of them, right? So the parallels, as you learn more and more about it, are unfortunate, and you can see how, from an advertising and marketing perspective, highly effective. So the next A, advertising, which is a little general, but being able to directly market to consumers. These are examples of, I think it's a vape pen and a cigarette. But being able to make these products, and then when you think about processed food marketing, it's cool, it's easy. Everybody does it. I work with clients who are trying to eat less processed foods, and they have to kind of go through this process where it's like, well, you mean you can actually live without eating these all day, every day? Like, the advertising has infiltrated our brain so much that it's just normal and everybody does it and it's easy and it's cheap and there's really no reason not to do it, right? So again, highly effective advertising. Next is age. The younger you can get them, the more they can buy. Children are ultra susceptible to marketing. I have two kiddos, 8 and 10 years old, and I limit their screen time, but the ads on the tablets that are popping up with food and games, like, they're highly susceptible, and if they see it, they want it. Cereal marketing directly towards kids, tricks are for kids, right? There's all of these, it's a very clearly, specifically targeted towards children, because it's the most effective, right? You get them young and you have them for their whole life. So the second pillar of neuromarketing is removing barriers to use. So the first one is teach the brain to want it, to need it, to crave it. And the second one is make it super easy to get it. So availability, making sure that it is everywhere. When you're driving, signs everywhere of how you can get processed foods quickly and easily. Vending machines in schools, in hospitals. Gas stations are really not just about filling up the car. It's about all of the things that you got on the inside. One client that I work with, we were talking, she was trying to avoid processed foods, and she had this problem every time she would drive home from her mom's. She had to stop to go to the bathroom, and she would go in fully planning to just go in and use the restroom and leave. And every time she would leave with, I don't know what her food of choice was, cookies, chips, whatever it is, right? Whatever is along the wall. But you walk in and you are inundated with all of the things that you need to have. Everybody else is having. It's super cheap. Why would you not, right? So making it super easy and accessible is part of the strategy. Also, this idea of cues and triggers, which may sound familiar from other addiction treatment. But if perhaps she is able to go into this gas station and then leave without purchasing anything, she was just highly cued, highly triggered. The brain has been activated. People have what's called a post-event collapse, where you successfully, maybe you came here today, like me, and you are not going to have a soda, you're not having soda, you leave, you're on the way home, so good I didn't have a soda, and you stop at McDonald's on the way home because you have used up all of your willpower and stick-to-itiveness, right? So just this idea of we are constantly cued and constantly told, and our brain is constantly being activated to want these things. Lastly, the last A is affordability. So food pricing strategies to make it seem like a really good deal. Buy 2, get 2 free. Plus you get a box of Triscuits for free too. The dollar menu, really making it appealing in terms of seemingly being very inexpensive. And they're able to do this because there are food subsidies that go to a lot of these processed foods, as well as sizing things to make it so that it can seem very cheap. Anyone who has ever purchased a bag of chips knows that the amount of chips you get inside of the bag, you're paying for a lot of air, right? So this is a strategic strategy. Oh, and my phone's going off. Yep. Okay, super. Okay, let's move on. So, learning assessment. What are the 5 ways that neuromarketing utilizes the addiction business model? And we're just going to say them out loud. Go. Addictive product formulation, yes. Advertising, yes. Age, yes. Availability and affordability. Perfect. Good job. Okay. Okay, so let's shift gears now and talk about how that impacts chronic disease. So I think we all I'm assuming we all have a sense of this, right? So we have patients, they have chronic disease. A lot of them, not all of them, they eat a lot of processed foods. This is a graph, and I realized when I was reviewing these that it's pretty small and hard to see. But what this is showing you is the amount of corn and wheat flour, total caloric sweeteners, frozen potatoes like chips and french fries, and then high-fat dairy, there's cheese, which I don't like being on this list, but anyways, and how much was consumed in 1970 versus 1997. This is obviously old numbers. That was a 37% increase. I do not know. I think this was this original data was pulled. I want to say from like FDA reports, and they're no longer reporting on these things, which has me concerned personally. I have to imagine it is significantly increased, but even if so this is like 400 and some pounds of processed foods per person in a year, which breaks out to 1.16 pounds of processed foods per day in 1997. So I don't know, my gut tells me it's worse now, but that's bad enough. And so what do we have? The state of chronic disease. I just pulled some, a smattering of stats from the CDC. 6 out of 10 adults in the US, this is US statistics, have a chronic disease. 4 in 10 have 2 or more. 20% of people aged 2 to 19 and 42% of adults have obesity. This is a specific reminder that and I'm trying to use inclusive language, I'm not super fluid with it, but people that have overweight and obesity, that is associated with the incidence of multiple comorbidities, including type 2 diabetes, cancer, and cardiovascular disease. 1 in 3 adults have prediabetes, and the part that's wild is that 80% of them don't know that they have prediabetes. And 15% of US adults have diabetes, which goes up to 29% in those over 65. So chronic disease is quite ubiquitous. Just a reminder again, this is not about blaming and shaming anybody about this. In fact, if anything, it's something that has been done to us, to our patients. But these are the facts. The CDC, which I consider to be a pretty, when it comes to lifestyle, they're rather, we'll say conservative. They don't want to tell people to eat in any certain way or do any certain thing, but they have identified that the key lifestyle risks for chronic disease are these 4: tobacco use, poor nutrition, excessive alcohol use, and then lack of physical activity. It's kind of hard to see. I have italicized those first 3. Do you recognize anything about those 3? They have all been furthered by this business model, getting us addicted to tobacco, processed foods, and alcohol in order to make us purchase their products. And they are directly contributing to health risks. So that's a bummer. So there's some work to be done for our patients and potentially for ourselves. All right, let's jump into a case study. So what we're going to do is I'm going to introduce the case right now, and then we're going to revisit this after a few slides. So this is a 35-year-old female. She had normal BMI, actually kind of fell towards the lower end of normal. Labs, all within normal limits, was called healthy, thin, no chronic diseases. And yet she complained of fatigue, feeling tired all the time. She would have like muscle aches and pains regularly, skin, like almost like I imagine it like a fibromyalgia where when you touch their skin, she had pain, acne, dry patches, and areas of inflammation on her skin. She found herself with low motivation, not really wanting to take care of herself, her family, not really having the energy to go do things. Is this working still? Just really having a really hard time taking care of herself and her family. And that actually caused a lot of shame for her to, she wanted to be doing all of these things and she just really couldn't muster it up. But she would go to the doctor and share these symptoms, and she would be told, everything's fine, everything's normal, go to bed earlier. Wasn't asked about that. If she had been asked, she would have said Mountain Dew pretty regularly. Cookie dough was a treat, lots of chips and French fries, some animal protein. That was essentially the diet she was consuming. She was very busy, had a family, and that was pretty standard. Anything jump out at you here? Obviously, you know the topic of this presentation, but anything we would want to assess, anything we would want to ask? So when I'm looking at it, I'm thinking we need to do some screening for depression. She's having trouble caring for herself and her family. She's got a lot of like kind of general, maybe like inflammatory type symptoms, but nothing showing up on labs. So they're not really doing anything to treat it. She was given symptomatic relief, antihistamines, topical steroids, ibuprofen, right? Headaches also were included in this. Anything else we're missing, you think, here? Okay. All right, so as of right now, food addiction is not included in DSM-5 related to substance use disorder. It's not one of the listed addictions. However, there are many organizations that treat and care for people with food addiction that have adapted the 11 criteria that exist to be related to processed food use. So I'm not going to read these. Each of the questions is going to go through each of these. So I think that's more useful. I'm going to, if you're open to feeling a little vulnerable, no one has to share the results, but do a little tally or keep track on your fingers as I'm reading these and tell me or don't tell me, sorry. Keep it to yourself. Keep track of how many of these you can relate to. In the DSM-5, the presence of 2 of these things for substances suggests the presence of an addiction, and the presence of 5 suggests severe addiction, okay? And reminder, we're not diagnosing anybody because food addiction is not in there. This is just a thought experiment. Okay, so I'm going to read these for you so you can think about them for yourself. Have you often found that when you start eating, you end up eating more than you were planning to? Okay. Have you tried to cut down or stop eating certain foods? Do you want to stop or cut down? Is this something that you have worried about? Have you spent a lot of time eating, being groggy from eating, or feeling tired and hungover from eating, recovering from eating? Do you have cravings or strong desires or urges to eat processed foods? Do you ever eat so much that it's hard to fulfill major role obligations at work, school, or home? Do you eat despite having persistent or recurrent social or interpersonal problems? Have you ever given up important social, occupational, or recreational activities because of eating? Needing to eat or not wanting to eat? Do you eat even when it's hazardous or dangerous to do so? The interpretation of this one could be difficult. You know, if you have a chronic disease that is worsened by certain foods, is that dangerous or hazardous to eat those foods? That's up to interpretation. Has your eating caused any psychological problems, like making you feel depressed or anxious, make it difficult to sleep, or causing disruptive fatigue? Has your eating ever caused significant physical problems or made a physical problem worse? Have you found that you need to eat a lot more of the processed foods in order to get the feeling you wanted than you did when you first started eating to feel better? And lastly, have you ever had withdrawal symptoms when you cut down or stopped overeating certain foods, such as sweating, racing heart, hand shaking, trouble sleeping, trouble thinking, feeling depressed, agitated, anxious, tired, and add headache in there? And then do you eat to alleviate any of these? I don't know about you guys, but when I read those, I had a lot of yeses. And I remember the first time reading those, I remember, like, who doesn't do those? That's normal, right? Isn't it normal to eat so much that you like feel like you can't even wear your pants? That's normal. Isn't it normal to want to cut down and not be able to cut down? I don't know. So let's come back to our case study here. So this female scored a 6 on that list. So 6 out of 11. Remember, anything above 5 would be classified as severe food addiction. So she's thin, labs all within normal, loads of complaints, feels terrible, scores pretty high on the addiction severity chart. There's really no, like, the healthcare system is not built for supporting this person, clearly, right? Okay, so I think my learning assessment question will really drive that point home. So first, which patient evaluation tool can be used to identify this addiction? And again, we're not diagnosing anybody. It's just a way of thinking about this challenge that your patients are having. It's not that they're lazy. It's not that they're not trying. It's not any of that. It's possible, likely, that many of them are dealing with an addiction, right? So what could we use to identify that probability? Hey, okay, good job. And true or false here, only patients with obesity or overweight or chronic diseases can have addictions to processed foods. True or false? Of course, right? Okay, let me see. How are we on time? Oh, see, I knew I was going to be speedy because I didn't have my notes. Okay, so you might be thinking, so what are we going to do about it, right? I personally had to go through a little bit of a like grief process for myself because I don't know, I'm a pharmacist, I'm a health coach, I am a certified diabetes educator, all of the health coaching trainings, behavior change trainings. And, I personally had a really hard time impacting my processed food intake when I began trying to do it. So education isn't enough, certainly. When we think about addiction, like treatment and support in other realms, we know education isn't enough. And so what I'd like us to do is take some time to kind of chat amongst yourselves. Feel free to share your score on the on the criteria if you'd like to. I have a feeling we're all up there, so don't feel bad. And think about some ways that you may be able to support coming at it from this different perspective instead of, you know, telling patients, oh, you just need to eat less, move more, dash diet, right? That's not going to be helpful in the setting of a food addiction. And so what are some things that we could do in the pharmacy setting, whether that's community pharmacy, in the clinic setting, even in the hospital setting? What are some ways that we can support our patients with processed food addiction? So we'll break into groups and chat, and then I'm asking everyone to share a few ideas. I do have some slides. I would love to not need the slides because you guys are going to have so many great ideas, but I do have some just in case. Okay, and go. I'm going to probably walk around also since we have plenty of time. So I was able to walk around a little bit, heard some really great ideas. Who would like to share some of the ideas that you came up with? I think we're supposed to use that microphone if this is being recorded. So if anyone would really like to say it, you can say it to the microphone. Otherwise, you can just say it and I'll repeat it into the microphone. Absolutely. So educating directly to patients. On the education side, now that you guys know about this, there's an opportunity for educating other healthcare providers, you know, your organizations. So the education piece, although not sufficient, is a super important piece. Awesome. Loved that idea. Some incentive. Right now, the incentives are all set up to purchase processed foods. They're cheap, they're easy, they're quick. Getting some incentives going, immediate incentives, right? Because the long-term incentives of eating quote unquote healthy food is you feel better and you have less chronic disease, but that doesn't really compete very well with the instant incentives of easy, quick, and cheap. So bringing those incentives closer to the point of purchasing is a really great idea. I love that idea. Yes, that actually came up on at multiple tables because there's the being able to access food, right? You need to have time to cook and prepare the food, and you need to have the skill set to be able to prepare the food. Related to that, something that came up was, you know, a lot of people have children at home that are very used to eating processed food and are used to the taste and texture and consistency of processed food. And now you may be trying to change the foods that they're eating. If it doesn't taste good, they're not going to eat it. And so being able to, you know, support the skill development of being able to prepare real food in a way that tastes delicious, because it is possible, can be super useful, not just for kids, but also for adults. We like to eat food that tastes good too. Sometimes our frontal lobes can override that more so than children, but not always. And especially not if you have food addiction processes going on, right? Then very difficult. Love that idea.
We talked a lot at our table about how our conversation with our patient would be similar to like if they're trying to quit tobacco. So helping them maybe track throughout the day, you know, what they're actually eating, which one is the hardest to cut out, what could you do instead, how could you change what you're eating to something that would be less processed, non-processed. So kind of that whole mindset of how we deal with tobacco.
Yes. And what do we call that? Motivational interviewing, everyone, right? I heard that said multiple times, which is amazing. So those of you who have done the certifications and who have practiced this with your patients, if you can have a conversation with your patient about improving adherence, about decreasing tobacco use, about any of these things, about remembering to take and removing barriers to taking your blood sugar regularly, they're all the same types of conversations and questions and strategies that you can use to have conversations with them about processed food. And maybe maybe some of us were having those conversations around diet and nutrition. I find that when I come at it from this perspective of like, this is something that was done to us, This is not a like a moral failing. This isn't you being lazy. This isn't you trying hard enough. And I come at it from that perspective. The amount of like compassion and just the brainstorming that I'm able to help the patient with is different than when I'm like, well, I wouldn't say this, but just the thought of like, well, they just need to try harder. They're not trying hard enough. I don't know if anyone, or even about yourself, like, I just need to try harder. I hear people say that about themselves all the time. And that's not really enough when we're talking about an addictive process here. Absolutely. Absolutely. That came up a few times, making sure that there's, ability to refer to whether it's like food pantries in the area or other resources for support in your communities. Super important. I know there are some pharmacies who have partnered with like, what's it called? Not a farmer's market, but where CSA, thank you. Yep, having CSAs and maybe like some of the CSAs are subsidized by some group or any ways that you can, you have more ideas? Amazing. It probably would be great for us to be able to put some resources together for people to be able to share these with patients. So, whoever wants to be on that team, let me know. Okay, amazing. Let's see if I had any other ideas that people are just dying to share. Am I supposed to be done? What time am I supposed to be done at? Okay, great. Let's see if I had any other ideas on here. Just this idea one more time, because this is super important. This idea of removing the blame, both to yourself and to your patients. Try to stop saying, just need to eat less and move more. It's not particularly useful. And having the sense, it may not be that all of your patients are addicted, but almost all of your patients are consuming addictive foods. And so whether or not they fall on the spectrum, whatever it is, it's harder to remove those foods. Engaging patients, motivational interviewing, asking, some of those criteria questions, you're not diagnosing, but being able to get a sense of, are they wanting to stop? Are they trying to stop? They're not able to stop. They've lost control. Getting some of that understanding can really help brainstorm with them. Motivational interviewing. Exploring your own relationship with processed foods. I found that to be, okay, I wasn't sure if I was going to say this or not, but I just decided right now. The case study was me. So for those of you who are wondering, that is me. I had to have a little bit of a, I want to have a religious reference, just like a moment of like, wow, like I am trying to stop eating these processed foods and I can't. And I ended up getting some support to do that. And it's difficult. So, if you yourself are trying to make changes or you're working with patients who are trying to make changes and they're struggling, I think having our own relationship with that can kind of really help us bring compassion to the table when we're having those conversations. I put on here, consider removing processed foods from your pharmacy. I always think of like hospitals. I know it's complex. What you keep in your pharmacy, what's at the hospital, what's in the vending machines at the clinic, they're complex. There's lots of reasons to have them or not have them, and I get it. It's like having cigarettes for sale in your pharmacy, right? That used to be pretty standard. So something to consider. And then referring patients to appropriate resources. You can have the conversations with people, you can motivational interview, but likely if they are actually experiencing processed food addiction, they likely need some significant support. There are food addiction support groups. I listed some here, not to be confused with weight loss programs. I didn't mention that very much, but those are two very separate things. Recovery from processed food addiction sometimes results in weight loss, but not always. It is two separate items, and often weight loss programs encourage processed food consumption. And so it's complicated. So just be aware of that. I've shared some Food Addicts Anonymous, Overeaters Anonymous. There is a website, foodaddictionresources.com, and they have an online community. So there are resources available that you can refer your patients to, especially if you aren't really comfortable having those conversations. Okay. Lastly, which of the following are opportunities that pharmacy professionals can use to support patients with processed food addiction? Education of other healthcare providers, education of patients and caregivers, motivational interviewing for behavior change readiness, and referral to appropriate support systems are the ones that I can. So, okay, thank you all. Here is my contact information. I think we have like 2 minutes, so I'm gonna put up the code. And if anyone has any questions, I think let's wrap it and feel free to come up here if you have any questions.